Good afternoon, everyone. Sorry. Good afternoon, everyone. Welcome to the foundation course in palliative nursing. Today, we are going ahead of our fifth session, that is Introduction to Communication. We have our faculty, Ms. Preethi HM, and our facilitator, Sister Shiva. For further facilitation and faculty introduction, I welcome Sister. Sister, over to you.
Thank you. Very good afternoon to all. Happy New Year to all of you. As Sangeet said, today we are going to learn about communication session. We all know that without communication, there is no relationship. So the communication is very, very important part in palliative care, and also we need to give a respect to the patient. Without respect, there is no love. So these all things we all know. So today we are going to learn about the communication skills. That is the basic things which you already know. But we are focusing on the do's and don'ts of communications. Today we have an eminent faculty, Ms. Preethi is here, who is our social worker. We have a social engagement department, community-based on the patient side. So she is working inside the patient care. And so she has many years of experience in counseling and all. Now she is a social officer here. So I think she is a very best person in this field. Welcome to Ms. Preethi ma'am.
Sister. Good afternoon, everyone. Today we are going to take a session on communication, which is a very important topic to learn. So I'm going to share my slide. Give me 1 minute. So, today we have a very important topic, that is communication, which is very important in palliative care as well as in the medical field, to know how to communicate properly with our patients and others which we are dealing with every day in our life. So, the main objectives of the section are: what is communication, the need of communication, positive body languages, bad and good communication, listening skills, what are the barriers that mm, is that will affect the good communication, etc. So we'll continue on with that. So before we go ahead, anyone who can share what you know about what you think communication is? A good communication.
Patient, staff.
Okay.
Nurses and doctors.
Okay. That is the
Staff
team.
and the
That is the team communication between patient, doctors, nurses. That's what you're mentioning about, isn't it, ma'am?
Communication is exchange the information to person.
Yes.
Share information.
Can you repeat it, ma'am?
Share information.
Okay, share information.
Ma'am, communication is a exchange of views, thoughts, perceptions from one person to another person's, madam.
Okay, different perceptions from one person.
Hello?
Okay, I can hear it. I heard it. Thank you. Thank you. So we are going ahead. We heard different views about communication from different persons in our class. So it's a therapeutic tool in palliative care or in a health department. Communication is very important. Like where serious illnesses happening, where a patient comes with a serious illnesses or a life-limiting illnesses, communication is one of the most important tools with the healthcare professionals use in giving the patient information that is needed for the patient to know about. That is in a real life practice. If a patient comes with sudden with the patient is diagnosed with a CA or with any other diseases, to break that news to the patient, we can't say it bluntly or openly to the patient that you're having this. You need a skill or a patient, a knowledge on how to communicate the news gently to the patient. So it's a professional therapeutical tool used. Communication is very important, and how to communicate with the patient in different situation is also what we should know about. So what is communication? Where to use it? When? How? Why? Who? So, to whom should we communicate? Why should we communicate? These are all questions we, each one of you can ask about. What is communication? Where is the importance of communication? Where should we communicate? When to communicate? Like a bad news or a good news or anything, or to talk openly with the patient itself is when to communicate. We should know the proper way to communicate, how, why, who. These are all questions that we always face in communication. So, what is communication in palliative care? A patient that is coming in front of us, she may be young, old, or in the middle age, in the coming with different, under different situations. She may be uncertain, she may be having fear, she may be having anguish, she may be sitting in front of us, a nurse, a social worker, a doctor, or anyone. She's sitting in front of us, she will be having all these inside her mind, that is uncertainty, fear, anguish. What is the doctor going to tell me about? What is the test result about? All these queries will be there in the patient sitting in front of us. So the patient and the family will be coming with lots of queries, lots of uncertainty, everything. So a palliative care team that includes a doctor, a nurse, a social worker, a palliative care assistant, a volunteer, whoever is this, should know to clarify the issues properly, should have a knowledge of things, what she is or he is saying, and what the patient is suffering from. A palliative care, each member of the palliative care team should know how to identify issues, to solve, to clarify the issues, acknowledge, that is, understand them, to know their suffering, to understand their what they are going through. These all can be understood only through a proper communication. You need to have a proper communication and the skill to have a proper communication. So the way these are some of the components which we use in. First is empathetic communication. What do anyone can tell what is empathy? That is understanding the patient in their situation and listening to them or hearing them in their situation. We should be in their situation, understanding them, standing in their situation and understanding, and provide information as and when needed. So when the patient or the family is talking, listen properly and provide information only when and when, as and when needed only. Don't interfere in between communication. Spend adequate time with patients and family. Don't be quick, don't be fast, don't rush in your communication. Spend time with the family and the patients, and only then you can have a good communication within a palliative care settings. Listens for feelings behind words. There may be non-verbal in their body language. There's signs, their signal, and their sitting postures, everything may be having a some unknown hidden feelings that can be revealed only if we have a proper listening skill and understanding their nonverbal cues also. Encourage and reassure while maintaining realistic hope. You shouldn't give any hope to the patients, false hope to the patients, but encourage and reassure them and be with them, listening to them, and throughout the communication, being accessible where you can be reached and when. So you should make the patient understand that where you can be reached, when and how you can be reached. There should be a constant communication or a good relationship with the patient and the family to have a good communication, open communication or a free communication with the whoever is coming in front of us. Observe surroundings in patient's home. So when we are going for a field visit or a home visit, these are some of the main things we have to look into. That is how the patient's voice, what are their nonverbal clues, what their feelings is when they are talking, how they are expressing their feelings, encourage them to talk openly, observe the surroundings. If we are going into a family setting, we can observe their surroundings only. It may be a sudden illness like a stroke or a cancer, everything may be suddenly diagnosed in a family where the earning member may be the bedridden person. So there may be lots of socioeconomic problems in the family. The patient may be, the family may be having uh, issues that can, their relationships may be having issues. So all these has to be observed while we are going in, while we are doing while the patient and the team is having conversation itself, communication itself, we should observe all the surroundings that's happening and even have a good communication with the caregivers or whoever is in the family also. Keep appointments. Let the family know where before going itself, call and tell them that we are coming so that they may be, if the patient is a bedridden or or if the patient has to be taken, all this can be priorly before going itself, we have to let the family know that we are coming. Maintain confidence. That's the most important thing. Whatever communication we do in a family or a patient setting, we have to maintain whatever they say we have to, it has to be within us only. We can't spread it openly or tell to others. It has to be confidential. So why communication is important for patients? It helps to express his or her needs or concerns. So when so most maybe in some situation we may be going to a new family or a new patient and seeing them for the first time. They may not be able to express his or her needs, concerns in the openly when we enter itself, but with some patients, we may have a close relationship because for some years or some day, for some months, we are having continuous visits with them. They may be able to express their needs and concerns while we are having a good communication with them. Permit ventilation of feelings. That is, lots of patients may be suppressing their feelings or they may not tell what they are going through. They may have uncertainty and they may have be anger. They may be suppressing their anger. They may have some queries. Some of the diagnosis what they are going through. They may not really reveal because of the suppressed feelings, but by slowly talking with or communicating slowly, openly talking with them, building a rapport with them, we may be able, a patient will suddenly, they may show these feelings, maybe it may be anger, it may be crying, or it may, all these suppressed feelings can come out in many ways. It can be anger, it can be sudden anger. They may show anger towards us. They may cry out their feelings. So these may all also in between communications. They may also ventilate or open up what they are having, and that can be great relief to the patient or even to the family members. Help some of the doubts, apprehensions, that is what is hidden inside them. They may have doubts like, am I going to die? What will happen to me now? Is what what will happen to my children's studies? What will how will my family live now? As he may be the only earning member of the family, so he may have doubts about his latest reports or some pains he may be feeling recently, which he can't express to his wife or to the children, because he may think that they will have more burdens, or not to burden them also. So he will slowly open up while we may be having a good communication. So communicating openly with the patient will help to clarify doubts or some apprehensions he may be suppressing inside. Give reassurance and realistic hope only. Don't give any false assurance to the patients, like during communication, like, oh, you can get well, or Amma, mother, ma'am, you will be, your pain will reduce with taking these medicines. Or you can walk slow after doing physiotherapy, like that, without knowing, without having a proper information, without don't without uh, any knowledge. If we are not sure about anything, don't give any realistic hope. We can only tell that, Amma, we can't assure you about anything. We have to have a talk with my senior doctors or whoever is senior to us, and then I will tell you, ma'am, what is what or if the patient is going on end of life or something like that, or suffering much or need immediate medical care, we will have to have an open talk with the sons or daughters or wife, and make them understand. So don't give them hope that the patient will be all right or something like that, but a realistic hope, or the right knowledge, right information should be passed on to the caregivers and the patient. And don't give reassurance also to the patient, so that they will have a high hope of recurring, or doing something, or taking medicines, or going to the Ayurvedic or something like. Each patients have their uniqueness, so each patient may be behaving different ways or talking in different manner. Don't give them reassurance while we are having a communication with them. Give the patient and family a sense of direction. We should be able to guide them properly during our conversation with them towards the right path. If some patients may be not willing to go for doctor's review, or go for a lab test, or a CT scan or MRI scan, be afraid of being afraid that they will be having some big issues or something, or to know the bad news. They may not be willing to hear the bad news, or they may be financially not able to afford it. So like that, lots of problems may be a family or a patient may be going through. So don't give a sense of direction. In the right path should be given while we are having a communication, or a open talk with, while we are visiting the patient at home, or even in a clinical settings. We have to give the rights and directions on how to move forward during the path of illness, or how to solve a problem. The right direction or the right information should be provided to the patient and their family. Help guide them in decisions making process. In some situation, they may be in a dilemma that they they may be sitting with, waiting for a visit to take a decision on what to do, how to move forward, what to do. Should we go for a doctor review? Isn't our visit is only our doctor is only needed. We don't have to go to the medical college. Maybe going to a medical college or to the nearest hospital itself, maybe traveling distance itself may be a long distance, which the patient may not be able to undergo. So, in many situations, they may need help or guide. So they may be needing some may be needing travel assistance, some may be needing an ambulance support. So different situation may need different decisions making process. So we will have to help or guide them in the right direction in our decision making, also in making a plan for the moving ahead on facing situation, or if it is a lifelong diseases, on how to deal with it. We may have to give right information to the family, also help the caregiver, make them know that what has to be done with the patient, how to take care of the patient. All these decisions has to be given to them during our field visit or when the patient is in front of us, assisting for coping with bad news. So every one of us may not be able to break a bad news in front of a patient or the family. It may take some time. So it may take, maybe the whole team may has to sit together, talk with the patient, talk with the family. Some may not be able to accept it. So these are also a good communication. A time spent, it may need a lot of time to break a bad news to a family or a patient. Sometimes the family not allow us to break the bad news to the patient because the patient not may be able to accept it or may have other psychological issues also. So some patients, some families may not allow us to break the bad news also, but but we have to break assist it. But it maybe it may only be the doctor. Sometimes it may be the nurse, the whole team. Everyone took the sitting, taking time and having a talk with the patient and the family, or the family member who all are the closest in the family. We have to call them separately, talk to them slowly and break the news to the family. And with their permission only, we can break any bad news or any diagnosis, anything like that to the patient also. So this is for us, like a nurse, a doctor, or a social worker, or whoever is in the team. How a good communication can build a good relationship or a good rapport with the patient or the family members. So a good relationship or a good rapport with the patient and the family will help each one of us to have less trust and build a trust with the whoever is the members of the family of the patient, everyone. We can build a good trust with the good rapport building communication with them. Better understand the impact of illness and that is we have to understand what is the illness, how long, if it is a lifelong threatening illness, or if it's it is if the patient is going to suffer for it, if it is a prolonged suffering, everything has to be understood by each one of us so that we can provide a good quality of life or a good service to the patient and the family. The patient's thoughts has to be understood while having a good communication with the patient and each member of the family. Only we can understand each patient and the family members. There may be a rift between the family and the members due to that happened due to the sudden prolonged illness of the patient. Maybe the patient is going through stress. He may be having anger anger issues. He may be not be happy with the caregiving of the family members. These all issues are there. So understanding the patient through communicating with them, having a proper communication with them only, we can understand the patient, what he is going through, what all problems he is having, what all physical problems he is undergoing through. All these can be understood only through proper communication. Then the patient's values, beliefs, concerns. Each patient may have their unique thoughts, unique behavior habits. They may have different beliefs. They may have concerns. One patient's concern, like, am I going to die? Maybe not the concern of another person who is a complete paraplegic patient who is completely bedridden. He may be having other concerns, other priorities which has to be na, na, taken care of by each one of us. Like a doctor can take care of the physical problems of the patient and the family. The nurses can listen and take care of the understand the pains, what the patient is going through. So as a team, these two physical habits, physical problems can be addressed by them, but the social, financial, every issues can be handled by a social worker. So each one of us has to understand the patient's beliefs, what's maybe some may not be having really religious beliefs. He may not be believing in the God because of the illness or what happened to the sudden change in the family. So these are all concerns and priorities we have to deal with. We have to provide a proper communication about the diagnosis and the prognosis to the patient. We can't hide them or give false diagnosis or prognosis to a patient or the caregiver. Provide the truth. What is the diagnosis? What is the prognosis? And how to deal with it. These are all have to be dealt with each one of us. Better compliance with managing. Compliance means the rules, each organizations may be having rules and hacks that guides us towards the right path, trains us towards the right path. So these have all to be maintained by each one of us in the team so that a proper teamwork can be done and the patient has a can be given a proper palliative care. So these are this is what did you understand from this chart? It's an important chart that is important in the communication. We are coming towards these parts, that is the importance of the difference in the words, voice, tone, body language, all these are we are going to look into. So 7% of the spoken words. So while in a communication, 7% is only spoken words, 38% is the voice and the tone we use, and 55% is the body language. While we are talking to a person or a patient, they look at, they hear 7% of our words, 7% of our words, but most of them will be our voice, tone, etc. will have 38% in the communication and 55% is in our body language, which altogether helps us to make a proper communication. So some of the positive body languages are proper eye contact, proper facial expression, tone of voice, body position, body posture, body space, touch. These are all important in a communication, in our communication. So be comfortable with this, be confident, be welcoming. There should be a comfortable while you are entering into a house. The person, the patient who is lying should feel comfortable with the person who is entering the person or the team which is entering and the team should be confident and the team should be also welcoming the patient as well as the family should be also welcoming us to so that we can have a proper. So let's look further into the each one of this. So this is tips for making eye contacts. So when you look, do it slowly. Don't look don't look while we are having a communication or a conversation with the patient or the family members, whatever it is, look straight into the eyes. That's a proper way of communication. Make eye contact. You should have eye contact. Don't look down or look away into some other parts, into the air or open area or something, but should have a direct contact so that you can have a proper communication with whoever you, with the patient and the care family members. Don't break your gaze to make a gesture. You can break a gaze or the direct eye contact only to make a gesture or a note, making the patient feel that the patient in front of him or the doctor or the nurse or the is listening to him properly. That gesture or a nod itself will make the patient comfortable that she's listening to my conversation or hearing what I am saying. So these are all important things that you should know. Don't the the nose in it is that don't look down or look away while you are having a conversation. So this is a good triangle. That is a good position where we should have a straight eye contact with, not to look at the forehead. The correct position is the two eyes and the nose, below the nose. Till there, it's a good triangle that helps us to have a good eye contact with the patient and to have a good conversation. This is some of the facial expressions. You can see in the face. Anybody can tell about the facial expressions that you can see in the. You can type it in the chat also.
Hello, ma'am.
Yes.
Hello.
Yes, I can
First
hear
one
you.
is giving smile, ma'am.
Yes.
Ma'am, first one is giving
Yes, yes, continue.
smile. Second one is just question mark, ma'am. Second one is some question mark. Third one is just little bit smile. Fourth one is laughing. Fifth one is also he is seeing with tearing eyes, some crying situation, ma'am. Just mild crying situation. Some sad mode. Last one is sixth one is some sad mode.
Okay. So these expressions also, each expressions are different, and a team that is entering into a patient's or a palliative care team that is or a nurse in a hospital setting, a nurse or a doctor who is going in front of the patient should have a pleasant smile. But the second one is having a frown or why should I be here? That look with the anger or a sharp look in his eyes. Will that help for a good communication? That sharp eyes and the frowning expression in his face will that if with that expression, if a nurse goes in front of a patient or a family, will there be a good conversation? So It's not good coordination. Okay, Rita. Confused. Okay. But it's not a confused, but different expressions that can come in facial expressions that each one of us can show in front of different persons while we having a communication, a pleasant face, a smiling face. These are all helpful in a good conversation. The third face is also having a pleasant face or a smile, just a little smile, a pleasant a pleasant look in the eyes. But the others faces can, while the patient is having a serious talk, can we laugh in front of him? Like, ha 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 ha. Can we laugh? Then what will the patient think? The patient will be confused. Why this person sitting in front of us? I am saying a serious issue. I am saying my physical pains and my problems, and the person in front of you is having a frown or a laughing face or a sad face, like she's going to cry or he is going to cry. Will there be a good communication between the between the two persons? No, right. Many of you are saying no, right? There won't be a good convocation between. So our facial expressions matters. We should have a pleasant face, a smiling face, a direct eye contact with the patient to so that the patient will have can be able to open up. A person going with a angry face or a frowning face or with a look like, oh, I just came to see you, I don't have time, like that, or a laughing face, there will be a breakage in the communication between the palliative care team that goes and with the patient. Yeah, in the hospital setting, the patient may be able, yes, Jyoti, in the hospital settings or something, the patient may be able to spread to others also. What fear he felt when the nurse came with such a face or a anger or angry face, but in a palliative care, when we are home or we are visiting the patient at home, the patient may, that rapport we have built may be lost just because of that small facial expression of that anger or a small laugh, the disinterest that is shown in our face, that facial expression itself will break the rapport with the patient or the family. Maybe a new till now and another nurse may have been visiting the patient. When such a nurse or or a new person comes with such a facial expression, all the rapport that has been built till now may be broken just because of that facial, just because of our just a small facial expression. Tone of our voice, very important. Can we go with an angry tone and say, good morning, sir, Acha, or good morning, sir, how are you? No, we have to have a pleasant, soothing voice. Hello, how are you today? You are looking so pleasant today. Had your tea, had your food, so that the starting of a conversation is built. The rapport can be built. A team can't suddenly break into a house to just look at the pulses, take the look at how many medicines, give the medicines and run out of the house. There should be, they should spend time with the patient. The patient may be looking forward to such visits each month. So the tone of our voices, that is how we address a patient, create a comfortable environment between caregiver and patient. Yes, Rita, very that is also true. So a facial expression or a tone will create a comfortable environment that helps for a good communication between the caregiver or with the patient and the nurse or the doctor also. Thank you, Rita. So we'll continue. So this is a pleasant smell. Earlier we used to have a corona, so within a mask, that smile will be hidden. But even then, our eyes will convey if we have a smiling face or not even within a mask. So a smiling, each one of us should have a smiling face when we are in front of a patient. The do's and the don'ts. We shouldn't, each one of us shouldn't avoid eye contacts, should not have a grumpy or a angry voice or a high toned voice, which itself breaks the communication between a patient and the nurse or a doctor. And we shouldn't have a irritated tone of voice also. That is, we shouldn't show irritation. Like, we shouldn't think that, oh, this patient is such a patient. She is an angry patient. She won't listen to me. Then why should I give her all the advice? Just, so that tone of irritating voice or a not listening or a not listening or a distancing technique from each of a distancing technique from the patient and between the nurse and the patient will also break so that is also all don'ts in a communication, and do's is, as I said, maintain eye contact, a smile. Now we don't use mask, but there should be a smile, and there should be a soothing voice, or your tone of voice should be such that the patient will have a be feel comfortable in our presence. Another important thing in communication is body positioning. That is, a patient may be lying down in bed or sitting in a chair, sitting in a wheelchair, in different positions. While entering the house, we can, or in a hospital setting, she may be in a bed, lying even in a house. A bedridden patient, bedbound patient may be lying in a bed. Some may be sitting. So the patient should be, each one of us should sit in such a way. So make a body position such that the patient may feel comfortable in communicating with the first patient. Look how uncomfortable. Can you see the first picture and say what is wrong and what is right? Is there anything wrong in that picture? Three pictures I have here. Anyone? Okay, I'll continue. In the first picture, the doctor is standing near the patient. So the patient has to strain his neck, put his head up to have make himself having eye contact with the doctor. He is uncomfortable. He may be having stress, maybe feeling pain in his neck, or may be unable to sit in that position for a long picture. So a long time, so he is having a strained position while the doctor is standing up. In the second picture, the same thing, the patient is comfortably lying down in a bed in his comfortable position, and the doctor and the team is sitting in such a way that the patient can have direct conversation with him in a comfortable manner. They are sitting in such a way that the patient is able to have a good communication with them without any stress. The second thing is that it is a small child. A doctor can stand if he sits also. he won't be having in the same, he won't be having a comfortable position to have a conversation with the child. So what did the doctor do? He knelt down with in the direct height of the small child, so that he could have a very good conversation, a friendly conversation, and look at the patient, talk properly, have jokes with, play with, in between, understands our physical problems. So the doctor is making the child comfortable in such a position, making the child comfortable by kneeling down in near her bed, so that the child is comfortable to have a good communication with the doctor. Next thing is a body postures. Two pictures are given. One is that a man is sitting with the legs up on the chair, while the other one is a lady. It can be assumed as a doctor or a nurse or whoever is sitting. She has a pleasant smile on her face, looking straight into whoever is sitting in front of her. Her hands is having an open posture. She's having a straight sitting posture, maybe leaning forward comfortably, so that they may have a open talk between each other. There's no obstructions in between. If the other if a doctor or a palliative care person sit with their legs up, or looks at some other turn and sit at some other persons, while will be will we have a good communication? No. So the second, that is why a body posture also is very important while we are communicating with the patients or whoever is coming in touch with us, while we are going for home care, or we are first time meeting a person, whatever it is, our body posture is also very important. Like I said, while talking, leaning forward, so that, but we shouldn't break the barriers of a patient, like their closed space should not be broken, but the space should be there. The whoever is sitting in front of us should be comfortable to have a free talk with whoever is in front of us, so that the doctors are leaning forward and showing interest to the patient, to what they are saying, what concerns they are having. So in the first patient, she is having a mood, sadness, mood. She is suppressing something. So each one of us have to have a pleasant, good a good communication can be had if we have a little leaned position while we are sitting in front of a patient. Jyoti was saying the nurse having smile face and also having good posture, that increase, yes, that increases a good rapport building or a good communication between the patient. Thank you, Jyoti. So this is respecting their body space. That is respecting the private space of, it's a, everyone of should know what, how much we can interfere into their space. Lying patient or a sitting patient or whatever it is, there are a limit to a boundary to how much we can enter into their personal space. Like we can't go and touch wherever we feel like, or go into their house and do whatever we like. So there are boundaries we should maintain while we are having a communication, or when we are having palliative care, when we are going into palliative care, home care also. So there are intimate space, personal space, social space, public space. So that boundary should be known to each of us, so that we don't break. If we break that, The communication will break there itself. If we break into their personal space, if we, without asking permission, getting their pulses or their BP checked, we can't do that. So before doing everything, we have to tell them we are going to take your vitals, sir, or whoever is ma'am, that we have to do so. So that can we do it? We have to take their permission before entering into their personal space. Social space and public space, we have, it's common for them. That is okay, but entering into personal space or intimate space is, don't break that with any what. A loving touch is very important in palliative care. Each patient may be, some may not be, the whole family the wife may be going for work, the children may be going for studies, the patient may be alone at home. In some houses, old age person, a frail person will not, the children will all be busy, they may not be able to visit them or sit and talk with them. So a palliative care visit or the visit from a palliative care team may be looked forward by such persons, an elderly person or a single person who is living alone in a person. So a loving touch may create wonders in such patients. So while talking, a touch in the shoulder or in the palm of the hand will bring smiles or open up a good relationship with the patient in a healthcare setting. So the core principles of communication is respecting each individual as they are. Each individual is unique. They may be different in characters. They may be different in their beliefs, as I tell. So you respect them as they are. Don't disrespect them. Disrespect to each person. Respect them as they are. Empathy. This is understanding that person by placing ourselves in their position. That is empathy, trust in the person, be open, be truthful to them, talk openly, build a rapport with the patient. Building a good rapport is very important in communication. Then don't be judgmental or consider persons as, don't be judgmental. That is very important in the communication. We may be comparing two patients with, oh, that patient was very easy to handle, very openly talking. Why is this patient so moody, so not even saying a word to me? She is just sitting. That is don't. So that patient is very angry and talking very angry. Why is she doing? She or he is doing like that? Just now I have gone. Both of them is having the same disease. Both of them is suffering from the same disease. Then why is both the patients different? So like that, don't be judgmental. Even before entering itself, don't listen to other stories which you heard from around or from whoever has gone before you. They may have different views of each patient. They may have had bad incidents in the past, but even if that is there, we shouldn't be judgmental to any patient. We should have an unconditional positive regard. So that is, we should consider person as a patient as a person. Each person is individual, and we should respect them as and whatever he is, even at whatever circumstances. He may be in a dirty house, in an uncleaned house, he may not be taking bath, he may be in a, whatever the situation or whatever, however the patient is, you have to accept him as he is. Now we are going into look into barriers of effective communication. So, anything you have to say before we going into another to the next topic? Each one of you, whatever we have. Any questions?
Hello.
Yes, ma'am.
Hello.
Yes,
Hello,
ma'am.
ma'am.
Yes, continue.
Previous, ma'am, previous the images are you shown to us, ma'am.
Yes,
That first one is a doctor body positioning, ma'am. They
yes,
regarding we are discussing body positioning instead of the health personnel. You are discussing regarding patient, regarding clients. Clients mean patient. You are discussing before image, ma'am. Here, first one is health personnel is standing in the left side of the client. Actually, doctors need to stand in the right side of the client. Okay, the doctor, mainly we are discussing here health personnel, not the clients, not the
yes.
patient. So first one is he is standing, his posture is, his position is very well. But instead of right side, he is standing in the left side. So that is the wrong one. Second
Okay.
one, we will come to the second one. Here also we need to discuss regarding the health personnel. Here, both doctors are
Your voice is breaking up,
here with
ma'am.
both health personnel, sir. They are sitting and discuss. Then third one is the doctor is hello,
Hello. Your voice is breaking up, ma'am.
ma'am. Hello,
Yes,
hello,
yes.
ma'am. First one is completed, no?
First I heard, second is this is from second it started breaking up. Can you be quick?
Second one, ma'am. Second one in that image also, both health personnel, sir. Ma'am, both health personnel, sir, they are sitting and discussing with the client. So that
Okay.
is also wrong image, ma'am. Third one, okay, the doctor is talking with the child, but he's some joking or something telling to the child that his posture also, that health personal posture also, it is not good, ma'am. Mainly these three postures are, it is these three images are not good. Hello.
Yes, ma'am. Sorry, I think she is getting cut off. Maybe each one of us
No, ma'am.
are,
No, ma'am.
yes, yes, but we are suddenly it was you stopped, so I thought you have cut
No,
the
ma'am.
voice. Okay.
Hello.
Hello, yeah, ma'am, so I think you can,
Continue.
we can,
Yeah, yes,
continue the
yes,
session and,
yes.
at the meantime,
Okay, okay, okay.
please
I'll
tell
go
her,
into.
please share, the thing,
Okay,
the
okay,
chat,
okay, okay.
so
So
that we can able to see it, no?
yes. So each one of us, as I said earlier, each patient is unique. Each one of us, our opinions are also unique. So I was just mentioning some good body positioning like pictures and all. We can discuss it after our class so that we can have a detailed discussion again. So now we are moving on to the barriers of effective communication. There are some environmental barriers. So where we are set there in a hospital setting, there may be lack of privacy. It may be a huge furniture, noise distraction may be there, crowded room. All these may prevent a patient opening up or having a good communication between the health in a health setting. Like a huge desk that creates a gap between the doctor and the patient and the caregivers. That's itself a problem. Like that, loud noises like clanging of maybe outside there may be vehicle parking or a loud loudspeaker being played, everything. These are all noise distractions that may interrupt a good communication. So barriers related to patient. While from the health workers side or the health from the what are the barriers that will prevent a good communication between a patient and the doctor or a nurse? What is it? The patient may be reluctant to disclose what she is feeling or what physical symptoms she is suffering from due to maybe the doctor may be a new person, she may be not be a open person to open to a new, she may be a closed, she not may be able to talk to a new person openly in the first sitting itself. So all these so that is a barrier that happens between a patient and the in a health setting. Lack of privacy, like we looked earlier, fear of she after this long period of checkups, lots of diagnostic blood tests, urine tests, scanning, everything. The patient may also all be stressed up, so that she may be expecting a bad news. She that that fear itself may prevent her from talking or having a good conversation with the doctor. Then fear of treatment being denied if they raise questions or doubts. That's itself a big problem. That is, if we tell something negative or if we question the doctor, if he disagree with what the doctor or the nurse says, will will they stop treating me or will I get a proper treatment? These are all questions that is inside a patient's mind or suppressed inside a patient's feeling. These all feelings, these suppressed feelings may prevent a good conversation between a patient and a doctor. Then while having a conversation, she may get suddenly, like I said, the patient may get anger issues, she may raise her voice, she may suddenly start crying or sobbing. These are all issues we have faced in front of us. So our emotion, she may be losing her, whatever suppressed emotion she may be having, it may open up in front of while we are having a conversation. So we should be able, uh, at that point when the emotions break out, the conversation breaks down. No conversation can be able to happen in that situation. So only a silent, supportive, supportive, uh, supportive emotion can be provided to the patient in that situation. Then medical jargons are technical terms used used to a doctor or a nurse or anybody who uses a technical term or a or a jargon to the patient. The patient may be sitting bewildered without knowing anything. She may not even be able to understand what that technical term is like. Instead of cancer, saying that it is carcinoma or like. If it is a heart attack, instead of that, angio, angio, heart disease, anything can different technical terms that is hard for a patient to understand. Don't use these medical jargons in front of the patients. She will be sick. She won't be able to. She or he maybe won't be under. A patient may not be able to understand these medical jargons. Don't use it while having a conversation. We ourselves may be a barrier in having a good conversation. Like we may be concentrating on our own physical task. Oh, how will be I able to be looking after all the patients within this period of time limit? There, how can I? get out of this, if we are visiting a patient at home, how long should I spend some time with it? So these concentrating on our physical task like getting paper, opening up a bag, taking the wire, taking the BP meter, BP machine out, mm, diabetic checking, diabetic strips out, everything, each one by one, while the not spending time with the patient, but concentrating on only on a physical task itself. The patient may feel, oh, she has come to take no just a physical checkup of me and she will be leaving. So why should I open up or talk with her? That barrier will be lost there itself. Then earlier itself, I said before going in to see a patient itself, if we hear some unusual judgments or assumptions from other persons, don't take it into us or go in front of the patient with that assumption or judgment so that we won't be able to have a good communication with them. With that judgment, if we go and have a talk with them, we will not be having a proper communication. Then lack of training or experience, in some situation that person may be new to the, like in palliative care situation, a new social worker or a new nurse without, she may be having nursing knowledge or a doctor studied MBBS but may not be knowing the palliative care right procedures. Then that training or experience, knowledge, skill, these are all lack of training of lack of all these will be a barrier in our communication. Then appearance, going shabby, not in a presentable manner to a patient itself will create a barrier. Facial expressions. But then if the patient will say something bad to us, that is in a worst situation, blaming something against us. Last time you came and gave me some medicine, this happened, so happened. The doctor is not, the patient may be having, from the last visits itself, the patient may be having a bad impression of you. So that in that situation also, there will be a barrier between the patient and you. Unfamiliar with language and dialect. We should use a language that is that the patient may be able to understand. We have to talk in their language. If a patient is able to understand only Hindi and the doctor is able to talk only in English, will they be having a good communication? No, there will be a barrier in the communication. The patient will something, the doctor will say something. Both of them won't be understanding anything. They may be in need of a translator in between. So that's what is I said as categorizing or labeling. She is the best cancer patient. He is a difficult patient to deal with. So these are all categorizing before we enter into a patient's house. That is assuming the so and so patient is like that. So we have to be before itself we take a precaution. So there itself a barrier arises. Paying salary. A patient is saying, Doctor, I am so worried, I can't sleep properly. I also have pain in the back. The doctor only asks about the pain. He ignores the patient's worry about not able to sleep, the worries, the stress he is undergoing, all that the doctor ignores. He takes only the physical aspect of the pain only. So paying selective attention to the same physical aspects and ignoring the others is also creating a barrier in the communication. never inquiring about the present physical condition of the patient is also a barrier. How are you feeling? Are you able to cope with the pain? Is the pain less now? There should be a inquiring mind in the person that is going in front of a person. Without inquiring, no physical condition or no good communication or a conversation won't be able to be continued between a patient and the using leading questions. What is a leading question? That is, your pain is better, isn't it? Within the question itself, the answer comes yes or no. The patient won't open up to say about his physical condition or tell in detail what is physical condition. The doctor itself has made a plan, made a decision that the pain is better. So, are you okay today? Finished. There won't be a good communication between the patient and the doctor. Closed question. Do you have pain now? The answer will be yes or no. Or I have pain in the stomach, this area. He won't say what, he won't have an open talk like where the pain is, for how long the pain is. The doctor hasn't asked any other thing. Do you have pain now? Yes, doctor. Then the doctor may give some small medicines and for prescribe some medicines, and the communication is closed there. So you should not have a closed communication with the patient. Premature normalization. That is, before itself declare thinking and say going that the patient is normal or the patient doesn't have any problems. Just have to go and just have a look into the patient, leave. So like that, a premature decision should not be made. Don't worry, anybody in your position will feel the same. Like another thing from the doctor saying that don't worry, anybody in your position that no, each person is unique. Every patient may not be having the same pain, the same different, same physical problems, nothing. So you can't take a decision in standing in the patient position and saying that, oh, today you are feeling the same. So I'll continue with the medicine. So don't do like that. So steps to a good communication is building a good rapport with the patient, having a long, nice talk with them, building a good conversation with them so that you can have an open discussions on their physical problems and their, so whatever the patient is going, whatever stress, whatever feelings the patient have, what doubts he have about his diseases, about the present conditions. You should have an open discussion with the patient. Through an open talk or an open conversation only, you can gather lots of information about the patient. Yeah, on what are physical conditions, social economic problems he is suffering to, what the caregiver suffering is, burden is, all these can be gathered only through a good conversation. Understanding the patient's perspective. That is, through an open conversation, we can understand the person's views, what he is thinking, how he is, what he is undergoing through, how he is going to deal with the problem, what his present stress or feelings are, how he is having a if he is having any mental stress, if he is able to cope with the sudden diagnosis, if he is able to all these person's perspective, how painful he is under, what all pain, what all if it is a small or a long-term pain he is undergoing to, there's no differences in the symptoms or he is having any new all these perception, what a patient is thinking or whatever it is, we can understand through a good conversation. Share information. The doctor can give many advices on how he can take care of us, take care of himself in the present situation. Both a good convocation can help on solving many problems of the patient and can help the patient to make plans for the future on how to move ahead in the present condition on the with the help of a nurse or doctor or a team of palliative care. We can arrive at agreements on problems or how to deal with different problems. Can we go ahead with the treatment on what everything can be arrived only with a good convocation with the patient. We can stop a conversation only slowly by rephrasing what the patient has stated. We can't suddenly stop a conversation we can having with the patient. We can only stop it slowly without any haste, hearing them, making after a decision, after checking them, after hearing all their problems, we can only stop a discussion slowly, not in a haste. So there are some verbal do's and don'ts and non-verbal do's and don'ts in a good and poor communication. So verbal do's are greet the family when we are entering into a family or when the patient and the family enters the consulting room, we have to greet the patient, introduce ourselves. We should introduce ourselves. We should ask them to introduce themselves. We may be knowing the patient, but whoever is coming along with the patient, we know sometimes during at times some new persons may be coming along with the patient. So we should have a introduction to that person to know who and what the relationship the patient is having with whoever is coming with them. Use open-ended questions, encourage the patient to speak openly. With that open conversation only, we can understand their problems or understand their different physical as well as socioeconomic problems with the open talk. Like I said, we have to rephrase whatever the patient said to confirm their diagnosis or prognosis or what their physical symptoms are there through small rephrases. Use empathetic statements when appropriate. So when needed, you can use small empathetic phrases like, "Oh, is it like that? Oh, I didn't know." Like that, empathetic statements can be used pauses when appropriate. So when the patient is continuously talking or telling them about their problems, pause when needed in between communication. Don't continue with like a non-stop dialogue, but stop when it is. Be true or honor in whatever information we give to them, whether it is prognosis or diagnosis or future treatment, whatever it is, it should be a truthful information. Verbal don'ts are avoid medical jargons. Like I said, a facial, while the patient is seriously telling us something, if the person in front of him starts laughing, that's not a proper way in communication. So avoid inappropriate humor, avoid ending the conversation suddenly. Don't compare your patients. Don't give false assurance. Do not ask leading questions. Always ask open-ended questions. Non-verbal do's, like I said, you should have a straight eye contact with the patient, have a pleasant, warm facial. These are all we discussed in each sections. So I am not making it wide. Leaning forward, respect the patient's need for personal space, smile and touch will bring magic to each patient, and listening. You should have a listening skill that is very important in communication. Without having a proper listening, or the time to listen to a patient slowly, the communication will be broken. Non-verbal tones are do not stare in their personal parts or body space. Do not break into the patient's comfortable zone. Unwelcomed facial expressions, angry tones. Don't show anger or indifference to your patient. Each patient is unique, so accept them as they are in different situations. This is listening. Listening should, like I said, you should have an active listening skill, not a passive, like, oh, I don't care about this patient, let him murmur or let him continue telling, I won't be listening. So, like that, a passive, you should not be a passive listener, but an active listener. Use open-ended questions. How are you? How can I help you? Do not interrupt in between a conversation with a patient. So active listening skills are simple languaging, nodding. Nodding itself will help a patient to build a rapport with your patients, because the patient may feel that closeness towards you. Oh, she is listening to me very closely. That clarity of what response, what answers we give. If we are not, if the patient is saying something and we are giving a different answer, will it be that there itself, the patient will go, she is not listening to me, she is in another world. So why should I say, open up anything to her? Or why should I talk to her or open up to her? So these are all factors. So you should have your responses should be proper or truthful, reflecting back, paraphrasing, making it short. Whatever they have told to you, make it short, make a small summarize it, and ask her back, so that the patient will understand that whatever she has talked to you, we have understood. Lean forward and paraphrasing. So, unnecessary talking, like continuous without allowing the patient to talk or without listening to them, we ourselves continuously talking, saying something that whatever we feel like, whatever our plans are, these are all barriers to effective communication. Communication is very effective only if there is an active listening skill inside each one of us. So, in communication, it's okay to say no. In some situation, we not be able to. We may not be able to give them advice. We not be able to have the knowledge to say what is in that situation. So, in that situation, we can say, I will take help from the seniors or whoever is more knowledgeable in that field, and I will let you know, and I will reach out to you and will let you know about it in more after discussing with those who are able to help us in that topic. So this is our Rajagopal sir, who always says that it's easy to destroy somebody with a few words, but it's also easy to lift somebody up from the depths with small, pleasant listening skills, talking to them, hearing them, being with them itself, a patient lying down with, being with them, understanding them, being in the empathetic with them itself will help. Knowing them in depth will help them more than having a few words, talking with them looking after their physical problems, living. So that is what is palliative care, going into the depths of each patient, each family members, knowing them, understanding them, and being with them as a supportive member among them. So I
Thank
think
you. Thank you, Preethi ma'am, for the wonderful session. Anybody have any doubts, please ask. So we have only 5 minutes more, so you can use that time for your doubts, clarification. Anybody? Neelavati ma'am,